Good afternoon, friends. What we wanted to do was to give you various scenarios of coronary artery disease and severe aortic stenosis. So presentations based could be ischemia based or sometimes could be heart failure. That is predominantly what we decide upon. But you could have left main disease, you could have different type of diseases presenting with heart failure, and something could be also single vessel disease. I wanted to present 3 scenarios, and we will have some discussion. We will have very brief presentation followed by about 5 minutes discussion interaction, and then tell you finally what we did. This is a 69-year-old male patient, diabetic, hypertensive, dyslipidemic, hypothyroidism, and then had a severe degenerative aortic valve disease. But if you see the history, post-AVR 2009. Sai, can you come onto the podium? So we had a bioprosthetic valve degeneration and presented with severe AS and LVF initially. And we also had STD changes. We thought it could be atrial fibrillation induced associated ischemia. Patient was stabilized later. Then LV function improved better. So it could be ischemia or it could be of AF related. And then we thought it may not, because coronaries were normal in 2009, we thought it could be all severe AS. We got a CTA by TAVI protocol. Then as a protocol in those days, definitely we used to do angios also. So angio revealed left main bifurcation disease. So once we had this sort of disease, see this, these are the dots of the previous bioprosthetic valve. The distal left main stenosis site. This is another view shows in ilivocaudal. Then this is again long segment disease in LAD. Then when we found this is tight disease. So we rediscussed with the patient, and because he has both elements now, both CABG and valve replacement is required, but he was pleading us for TAVR. This is one scenario by which we will find. Another case scenario is a 65-year-old gentleman, diabetic, hypertensive, and had history of anteroval MI, PCA done in 2010. Now presents with exertional breathlessness, angio done outside in Maharashtra state, and he was referred to us with the advice of CABG plus AVR. But by the time he reached the hospital, his heart failure worsened, BP was low on inotropes, 70 millimeters Hg. Creatinine, which was 2.1 before angio, worsened to 5. Then current admission, we stabilized it was 3.1. So dilemma was what to do. These are ECG presentations like left bundle branch block, and also echo see that severe renal dysfunction, severe aortic stenosis. A lot of hypokinesis in multiple areas. Then see this echocardiogram, also some mitral regurgitation, what we noticed. Sometimes we have also seen severe mitral regurgitations also with AS alone regressing. So gradients were actually significant. So that is this is the angio presentation of that patient when we worked up. He has, as we said, LAD also a tight stenosis. L6 is occluded. Then RCA again is a critical stenosis. So this is the second scenario. We find critical TVD with severe aortic stenosis with CKD. This is a relatively simple one. 81-year-old female, risk factors evaluated, has just proximal LAD disease. This is the right picture. This is the left picture, which again has a critical stenosis of LAD. So we'll stop here and then take some discussion points how to proceed with these patients and take opinion. Then finally we'll show you what we did. So what I presented is one was a degenerative bioprosthetic valve with critical left main. Second patient was a critical TVD along with CKD and heart failure presentations. Third patient is a straightforward single valve disease presented with AS. I think we can discuss, and on whoever is there, probably Padmanabhan sir or Sai, who can just briefly talk about this, and madam, and then any questions or thoughts from audience also we can take.
The first case which you have shown with the critical left main along with the severe aortic valve stenosis, would you like to do the PTCA first, stenting for the LAD, for the left main, or in the same sitting, both, or sequentially like first TAVI and then
yeah, that's what we need to discuss, presented.
So I would suggest that if patient is having ischemia-driven symptoms, then probably the PTCA should be done first. Or if the patient is totally asymptomatic and more of a dyspnea and the failure symptoms, then probably we have to go according to the patient clinical scenario. That would be, I think,
correct.
in the presence of a bioprosthesis already. First will be PCA, then only the...
Okay. Sai, you want to say anything?
All three great cases, Srini, brilliant academic cases. For the first case, if the patient, since the patient already has open heart surgery and has in place, I just missed the age of the patient as I was walking in. How old was the patient?
70.
70. So in my practice, I have a rule, less than 60 surgery, 60 to 70 we decide in the heart team. Actually, everything is supposed to be decided by the heart team, but I'm cheating a little. And more than 70, they usually go for TAVR. This case is interesting. Patient is 70 with an aortic valve that requires intervention with left main. I would still be inclined to offering left main PCI with TAVR as the first option.
We pleaded the patient actually to undergo surgery because he needs both CABG plus AVR now. But patient, these are words of patient I'm telling. Though it is done in a good institute, I'm not saying it a small center. I had terrific experience in post-bypass. Please, sir, I don't want post-valve before. Please don't subject me to that procedure again. Do something. I said, there's more chance of recurrence, left main bifurcation, all that we explained. He said, anything is fine, sir, but please avoid surgery. That was his request. So then we have to do a good job if you are doing such patients. So see this ischemia being followed by then what we planned is because of requesting, this is a critical left main. Presentation was also ischemia, so you have to tackle coronary artery disease first. Then we did, these are the serial steps, it's out of purview of discussion. Wired both and then we did first kiss. This is the BK crush technique which we did. Because LCX ostium was also diseased here, it is important to cover that and do a tooth stent technique. And then finally we did a final stat and did OCT. And then again for sake of time, I'm edited all that. And finally, we had good areas in OCT and the LCX ostium was also covered well. Left main area what we obtained was also quite 12.6 and happy to say that procedure went well. And then later on after this initially we planned, we waited for about 4 weeks and then planned this tower also with self-expanding valve and everything went well. And then patient is doing fine on follow-up. He came for follow-up in the times of online also he's doing well. So in other words to say if patient has critical ischemia as presentation, we tackled that first and then you could have also, some could argue that CABG plus AVR could be done but patient was requesting. That's why we tackled, but we are doing the procedure, such sort of complex DK crush and all, take help of imaging, do a right job, otherwise it is likely to come back. Patient fortunately in 2 years he is doing all right. The second case, if you recollect, was again difficult case, not very old like before, but about 65 years patient, diabetic, hypertension. Added problem here was CKD. And patient has presented with the old interval MI and also, sir, you came, Mr. Kapoor, sir, please join. So also presented with LVF and then creatinine was worsening. So when we evaluated, he has that sort of disease, a critical instant restenosis type of problem in LAD and LCX totally occluded and RC also had a critical disease. So in that scenario, because the patient is predominantly presented with heart failure, for sake of time I'm just proceeding, presented with heart failure, then low cardiac output state, that's where probably doing of LV evaluation also be done. Significant myocardial viability was seen in SPECT. So it is all, we thought it is hibernating. Surgeon felt it is too high risk for surgery because the BP was low. It's easy to say surgery, but operating in 70, 80 years blood pressure and patient had severe dysfunction, we can't blame them also. So then because of this, we worked up and then with a low protocol in CKD patients is we just image only the aortic annulus part with 30 cc contrast and then decide on that. People are doing with TE also, one of the technique covered, I have shown that. But the hemodynamic data, in spite of patient having severe dysfunction, had a 70 mm gradient. So we did, edited the steps, we did a balloon expandable valve because I thought it was single go without wastage of much time, it would be good result. That patient improved slightly. On day 3, day 4, because critical blocks was there, day 3, day 4, monitoring creatinine, we tackled coronary artery right, this is, post is the disease result. This is the LAD, which was very ugly looking, but fortunately with multiple steps I edited, this is the post-procedure LAD result. And this is LCX, which was occluded, And after that, it has opened up well, though there is some diffuse disease because of diabetes and CKD. So immediately, the beauty of this TAVR as well as procedure is LV improved, though it didn't become totally normal, but immediately it had a dramatic symptomatic improvement first of inotropes, and the patient became all right. MR also was slightly decreasing. Then creatinine improves. That's why we keep telling TAVR is not a procedure only for aortic valve, but LV function improves, systemic perfusion improves, and the creatinines also improve. That's why we felt very happy, and patient could go back to his bank manager about to retire. He would go back and with very nice dressed, and people couldn't recognize him that he was such a sick patient. That's the beauty of TAVR, and taking care of the heart failure presentation. So we tackled TAVR first and then treated coronary artery disease also. The last case I think is a relatively simple one. This we could come across. Some people could argue that you may avoid doing anything, but it was proximal LAD, we thought we could do it. Otherwise, if it was more distal, we could have left it. But proximal LAD and critical, then we thought we can do PCI in both sitting, both in same sitting. But it was slightly challenging in elderly. What we thought is simple. It was little complicated, calcium and all that. It needed post-dilatations. And by the time we finished this procedure itself, it was about half an hour, 45 minutes. And then successfully, as God's grace, this took some time, but at TAVR we could finish it sooner. And finally, we did both proximal LAD stent as well as TAVR. The TAVR steps are regular, which all of you know. We did pre-dilatation, then balloon expandable valve, and the procedure was done well, and patient did not have any residual gradient or regurgitation. But generally, they could have some slight problems during this thing, and if you stent in the same sitting, sometimes you can't reverse heparin. That's why it's preferable probably stage unless it is a financial constraint or something where you tend to do both procedures together. If you, without proximal LAD, if there is branch vessel disease, small vessel disease, people are leaving it also because it didn't make much difference. On the other hand, if you address together, it had slightly increased bleeding risk in some of the trials. This is what this trial showed. And as we're nearing time, I don't want to go into details of these trials, but timing of PCI in TAVI, basically we decide by presentation of patient. If patient has acute coronary syndrome type presentations, like what we have seen in the first patient, you tackle CAD first and then also do TAVR later. On the other hand, if a patient has heart failure presentations, you tackle severe AS first and then probably stabilize a little, especially when this patient has high creatinine, then probably plan the procedure in the pre-discharge. And the single vessel disease, straightforward, sometimes people are recommending combination too, but I would prefer avoiding it unless there is some particular reason for doing it together. So those are the case scenarios, and I thought different type of presentations, how we dealt could be explained case-based. I think I'm up for the time. If any further questions or comments, the take-home messages are what I've mentioned here. Thank you for patient hearing, and final comments by any of the chairpersons, panelists, and otherwise go to next presentation.
I think we should be discussing about the coronary access.
That's my next talk, sir.
Next is that we put after how to do.
But before we go on to that, excellent cases, Srini. And I think with the number of TAVRs exponentially increasing in India, we are going to be more and more put in situations where we have to decide. We are going to see patients with coronary artery disease and TAVR, and we are going to have to decide which to do first. Do we do it together? Do we do it separately? Because cost is also such an important concern. And Srini summarized it beautifully. There is no one glove that fits all. First, you identify what is making the patient sick. If it is coronary artery disease, treat the coronary artery disease. If it is the aortic stenosis, treat the aortic stenosis. If the patient is too sick, then you have some via medias where you can do a small balloon just to stabilize the patient and then do the coronaries and then wait for him to stabilize and then go back and do the TAVR. But it is a patient-specific approach, and that was a beautiful presentation, very well summarized by Steve.
Thank you.